think everybody has made it in from the waiting room. Good afternoon, everyone. Thank you so much for your patience. We were having some technical difficulties with our Zoom meeting, but we're glad you're here. It's great to see you all. And welcome back to another week of Superior Health COVID-19 Nursing Home Leadership Roundtable. I'm Kelsey Ostergren, and I'm joined by my program co-leads Jerry Hineker and Kim Heft. We also have Julie Campbell with us today, who will be facilitating our Q&A portion of the call, as well as another one of our Superior Health colleagues, Gray Ficker, and he is going to be presenting on COVID vaccine adverse event reporting. And I just wanted to give a quick shout out because this topic actually came as a recommendation from this group. So thank you for that recommendation and idea. We always are open and welcome any suggestions that you have. So if there are other things percolating or that you want more information on, let us know. We're happy to add that to our list of topics because, again, we want this to be meaningful for you. As always, just an open invitation to participate in these sessions, however it makes sense for you. We will always start with our education portion of the event, but then really want to turn it into open discussion. So if you have questions for us, for the presenter, for your colleagues, that is a great time to ask anything that's on your mind, whether or not it's related to the topic that we cover. Slides for our session today are available. We will put a link to those in chat. And at the end of the event, we will also have our evaluation form that we welcome your feedback on, but that link will be coming a little bit later. So all of that said, Gray, welcome. We're so excited to have you. The floor is yours.
Great, happy to be here, and thank you for inviting me to report or present on this topic. So let's begin here. So I'm a social epidemiologist, which means I am a disease detective, and I use biostats or biostatistics to help structure and guide my investigations. I'm also an artist, so I understand visual play and perception, and I'm bilingual and have no conflicts of interest. So we're going to talk about, here's our agenda today. We're going to talk about some vaccine myths, and just a fair warning, the images that I'm going to show are a little strong, and some of them are difficult to understand. So just keep that in mind. They are myths. And then COVID-19 vaccine overview, VAERS, the vaccine adverse event reporting system, interpreting results, and the clinical immunization safety assessment, CISA project, and patient provider resources. So that's what we're going to go over. Really great quote that I learned from graduate school is that all models are wrong, but some are useful, from a biostatistician or a statistician named George E.P. Box. And so this is the first vaccine. This is the perception of smallpox vaccine or cowpox from 1802. And as you can see, it's very confusing and very strong to look at. But what's happening is that there was a fear that vaccines would give you an actual disease or disfigure you. So you can see here, vaccine recipients are turning into cows. Features of cows are growing off of their body parts and faces, and some of them are even giving birth to cows. So that's a little extreme, but it's how people still perceive vaccines today. And this is the next one. It's called the smallpox vaccine monster or genocide. And the smallpox vaccine monster depicted here is, like I said, visually striking, but it's a laughable image when we consider what is written here is that smallpox vaccine would not only give you smallpox itself, but give you additional diseases like syphilis, cancer, leprosy. And this is similar to the fears of today that vaccines cause birth defects and autism. But unlike today, this could have been a potentially singular source of information for a person or group, whereas nowadays we have multiple sources to consider simultaneously. So it can get pretty difficult. And then this is a more recent image called a meme that are often shared on the internet. And it reads, "He's perfectly healthy, doctor." I agree. So let's get into let's get some vaccine into his system and start him on a lifetime of unnecessary medical treatments. And this is the myth that medical problems and diseases are caused by weak and moral and physical character, and that vaccines are unnecessary and diseases and infections are not to be taken seriously. And we have forgotten how bad these diseases can really be, and that to many pain and memories of these infections and diseases are very real and very present. And so associated with disease are those emotions, and some people can handle it and some people can't, but everybody's imaginations and their responses are real to them. So we want to focus on meeting them where they're at and empathizing with their situation rather than sympathizing with them. And if you have someone who doesn't see vaccines as a necessary option, maybe they've forgotten illnesses like meningitis can cause permanent deafness, learning disabilities, mumps can cause infertility, polio can cause lifelong problems with mobility and breathing. And I think when people think about vaccines, they forget that experimental treatments like for COVID-19 are probably a lot less reliable than just getting a vaccine, which is a proven, at least, overwhelmingly strong evidence that they are functional and work all over the world. So next one is, sorry, here we go. This portrays a couple different, this is actually a perception of people who don't understand vaccines are also known as anti-vaxxers. We can see here that it's not just people who don't believe in vaccines, it's also people who do think that vaccines are effective, and that we don't often treat people who have lacked to same access to education or even have the same sense of social connection where they would get information to help them, or they have pressures to not get vaccinated. They're treated just as badly sometimes or inaccurately as people who don't understand vaccines or don't believe in them. And so this is an example of rhetoric or response meme. So unfortunately, vaccines don't offer 100% guaranteed protection, and they work instead to eliminate disease in populations. And herd immunity is a theory that was debunked in the 1990s, and it's a phenomenon rather than an actual causal relationship. So again, we see the difference between association and causation. And there are ideas that vaccines are unnecessary, that sick people are disposable, and again, illness is not to be taken seriously, or that it's about an individual and their situation is fine, so therefore it will continue to be fine, when unfortunately it doesn't work that way. And again, hammering it home, correlation does not equal causation. This is a myth that vaccines cause widespread death. Of course, there's always going to be risk associated with any type of intervention, but that doesn't mean that every single person or even a large number of people will experience adverse events, and they definitely do not cause widespread death. So this first image on the left is a more recent image that refers to VAERS, specifically that vaccine adverse reporting system, and a misunderstanding of a statistic that was reported. And on the left, we see an image from 1898 that describes a messenger coming to give vaccination information or forcing people to be vaccinated as smallpox as the messenger of death, which is, again, pretty strong. So I apologize for any discomfort or sad feelings that come along with this, but I think it's important enough to address and think about. And if you need help, please see me after. If you need help talking or understanding these images as well, we'll get you set up with some assistance. Okay, so again, let's resume. Let's summarize this. Vaccines, a myth is that they can cause disease, especially the ones they're trying to prevent, or that they can cause additional diseases and health problems, that vaccines are unnecessary and illnesses are not to be taken seriously, and that vaccines cause widespread death. So the root causes are often the fear of the unknown. It's scary to be told something that you can't, or describe something that you can't see, or understand or comprehend. It's outside of your abstract world or your individual world. And it's hard to deal with the reality of disease sometimes. So sometimes it's easier to not address it or not deal with it until you have to. And then another myth is that, or idea is that diseases and sicknesses, illnesses are caused because we're weak people, or we have weak moral and physical character. And there are different types of collective memories that happen in populations. So some people will perceive and understand events differently. And there's often a mistrust of authority or anti-intellectualism. People don't understand what information they're getting, why it's important, or the differences in context and object. And that's very important to think about when it comes to group thinking or mob type mentalities as well. There can be a lot of social pressures and difficulty with giving yourself time, and especially if you don't have access to things like everything you need to take care of yourself, and education, and so that these all are connected together. Basically, there's a lot of not only disparities in health, but also health literacy. So it goes into that. And let's see, I wanted to mention some other examples that can come up, or ways to help talk to your patients. If someone is going to go on a trip, most likely they're not going to go to a TripAdvisor website or a tourist website designed for consumption or of goods. Basically, planning a spa treatment is not the same as going to the US visa website and asking for traveler information. It's not the same as going to your travel nurse and getting help with planning your trip. TripAdvisor is meant for anyone to report any type of information about how they experienced a country or a hotel even, whereas the US government does not care whether you understand the policies or not. Their rules and regulations apply, and so you have to follow them, or they will help you comply outside of your control. And so it can also be as frustrating as talking to somebody who doesn't believe that the earth is round, and people who don't understand that online shopping is often sponsored, and that vitamins and pharmaceuticals are two different types of ingested treatments that can be possible. And for example, the FDA since 1990 does not regulate vitamins in the same way that they do with pharmaceuticals, and that's often very confusing for people as well. So we're going to talk about just some up-to-date information with COVID-19 vaccines. So as everybody knows, there's 3 types of vaccines that are available in the US, but I found recently that FDA on their website said they're going to approve some brand names for these vaccines. So Comirnaty is going to be the Pfizer BioNTech vaccine, Spikevax is going to be the Moderna vaccine, and the Janssen is of course going to be Johnson & Johnson's Janssen vaccine. And some of the vaccines that are available outside the US, just because you might have patients or providers that ask about them or mention them, are as listed are also AstraZeneca, Covaxin, Covishield, BIPV, Sinopharm, Sinovac, Novavax, Covavax, and Covidencia, or Covidencia. And then, so here's an example of the way that I would like to present information. It's a very bright image. There's a drawing, people can relate to that, and it shows that very simple People who are unvaccinated have a 5 times higher risk of infection than people who were fully vaccinated with a booster. And that includes the Omicron variant. So people might want more information, of course, about those, but you can provide those in detail as asked. But what's really important is highlighted there, the 5 times higher risk of infection. And this is another chart I found from the MMWR, which shows, again, the solid line on the top are unvaccinated people, and you can see that large disparate change or difference, rather, between people who are unvaccinated or even one dose of a vaccine with or without the booster. There's a very large difference, and you can even see that cases and deaths are very large, and it includes the different types of variants that are present in the US right now. So again, vaccine adverse event reporting system is VAERS. And what it is a national early warning system to help us detect possible safety problems in US licensed vaccines. It accepts and analyzes reports of adverse events, including possible side effects. And it's following vaccination. It's not designed to detect if a vaccine caused an adverse event. It can identify unusual or unexpected patterns of reporting that might indicate possible safety problems requiring a closer look. So for example, I found someone when I went on to CDC Wonder to pull some data that there was a patient who had a shoulder injury that was reported following a vaccine. And that has nothing biochemically, biomedically, or biomechanically to do with a vaccination. And there was also an example of a patient who was reportedly died within 665 days following their vaccine. And that would not have anything to do with the vaccine itself, but it's still reported in VAERS. So it's not designed to detect if a vaccine causes an event. It's designed to track anything associated with reporting to help us see if there's anything we might have missed in the data or different types of investigations that we might take. So it's managed by the CDC and the FDA and agencies of US Health and Human Services. It's collected nationally in all US states and territories, so that's some of the strengths. Anyone can report it, which is nice because then people, if they're wondering about something or if they didn't get a chance or they're not sure whether their provider reported something, they're able to do that. It collects information about the vaccine, the person who was vaccinated, and the adverse event itself, publicly available, used, like I said, as an early warning system to identify rare adverse events, rare, and it's a tool for identifying potential vaccine safety concerns that might need further study using more robust data systems. There are many limitations. It cannot determine if the vaccine itself caused the reported adverse event. It can cause confusion with publicly available data from VAERS Wonder, specifically regarding the number of reported deaths. And there have been instances where people misinterpreted reports of deaths following vaccination as deaths caused by the vaccine, and that is just simply not accurate. VAERS accepts, again, all reports of adverse health events following vaccines, but it doesn't judge whether the vaccine caused the adverse event. And some reports to VAERS represent true vaccine reactions, and others are coincidental. They're adverse health events and not related to the vaccine or any vaccination. And overall, again, a causal relationship cannot be established using information from VAERS reports alone. Okay, more limitations are that generally it's not possible to find out if VAERS data if a vaccine caused the adverse event reported in VAERS. And submitted reports often lack details and sometimes contain errors. And serious adverse events are more likely to be reported than non-serious events, and it could be repeated as well. And the number of reports may increase in response to media attention and increased public awareness. And VAERS data, again, cannot be used to determine rates of adverse events. So since 1990, there have been over 1.6 million total VAERS reports about all vaccines. So that's 32 years. And since this table includes only the reports available for COVID-19 vaccines that was reported by VAERS. And remember, the COVID-19 vaccines themselves have only been available since 2020. So the J&J vaccine accounts for about 4% of all VAERS reports. And while the Moderna and Pfizer BioNTech vaccines report about 50% of all adverse events together, and less than 1% are either people who didn't know what type of vaccine they received or received vaccines available outside of the US. That tells us that something weird is going on, and it's potentially misconstrued. So we see here, for example, there's about 630 birth defects that were reported by VAERS, which is about 0.04% overall. And this is for COVID-19 vaccines specifically. Since July 7th, 2022, it's reported weekly and it's cumulative. But we need to understand that birth defects affect 1 in every 33 babies born in the US every year on average. So that translates in about 120,000 babies. So each year, the total hospital costs for US children and adults with birth defects exceeds $2.6 billion. And that doesn't include outpatient care or provider charges, but that is nothing. The 630 sounds like a lot and it sounds sad. Like obviously we're all sad to hear that, but it's nothing in comparison to 120,000 per year on average. So that's something to consider. And so we see here, this is the Moderna and Pfizer vaccines have about the same amount of adverse events associated and reported through VAERS, while J&J appears to have little issues, but less people get the J&J vaccine than the Moderna Pfizer vaccines in the US. And Moderna and Pfizer vaccines also get more attention in mainstream media. And the J&J vaccine has more verified side effects and adverse health events potentially caused by the vaccine after investigation, which is why the use was suspended. And reports of the Moderna vaccine also have possible cardiac causes was debunked and explained, although there is reportable risk that was reported and updated by the FDA and the CDC. So see, we have the comparison here. And then that's the Moderna. That's the Pfizer BioNTech. And the next one is the unknown. So I'm using multiple screens, so that's why I'm going back and forth a little bit. Okay. And then this is an example of what providers are asked to report, or anybody is asked to report through VAERS. So if they've just had a reaction following the vaccine, if they've contacted their health provider, the online form, they can download a PDF, and that they need to seek emergency help if necessary. There are also some legal requirements for reporting to VAERS. It's co-administered, like I said, through the CDC. And they have to occur within a specific time period. So it's usually that 10 to 15 minutes that a provider is tracking right after you receive a vaccine, where they sit and wait if you have an adverse health event. And it's also used to help out with manufacturers finding out if there's any interactions that are easily found and they have to list as contraindicators for further doses of a vaccine. And also if someone, or if the CDC and FDA are able to investigate and find that there has been an instance of fraud, they are able to fine people, and there will be legal follow-up and consequences potentially. I don't think people realize that either. So people are strongly encouraged to provide adverse events to VAERS reporting, whether or not it's clear that the vaccine caused it again. There are always going to be vaccine administration errors, and vaccine manufacturers are required to report all adverse events that come to their attention. So here's some reliable information. The Clinical Immunization Safety Assessment, or CISA project, was established in 2001. It provides a comprehensive vaccine safety public health service to the nation. It addresses the unmet vaccine safety clinical research needs of the US, the National Network of Vaccine Safety Experts. So it's the Immunization Safety Office of the CDC, 7 medical research centers, and additional partners. And you see here, I did some digging and I found the maps. Because people who read this will ask, well, where are these? Where are these additional partners? Where are these hospitals? What is this? So Kaiser Permanente, Johns Hopkins, Duke, CDC, Boston Medical Center. These are well-known and very central, large population areas. And they report with CISA. And then we also have Harvard Pilgrim, again, Kaiser Permanente and other places, and health partners in the Midwest as well. So they do have a pretty good distribution. And there's also the Vaccine Injury Compensation Program. It's separate from VAERS and CISA, but it's administered by the Health Resources and Services Administration. But they make sure on their website, it's very clear that reporting to VAERS does not equal filing a claim, and that they can find more information on how to file a claim using an online link and phone number and visiting the website. And then here are some public resources for talking to patients and providers and their families about VAERS. So fair warning, it is a little bit more text and less pictures. It's not accessible to someone with an 8th grade reading level. So what is really great though, there are some presentations here and YouTube videos on vaccine safety and how to understand vaccines, especially for COVID-19, that the CDC has put out. And there's even a phone app, and a lot of information that is accessible to patients and providers or people who have lower health literacy and literacy in general. So any questions? If there are no questions, we can watch a short version of the CDC video. I thought that might be nice, but I want to make sure I answer any questions before that. I haven't been able to check chat either. Okay, well, let's go and watch the video then.
We're still seeing your PowerPoint slide, Gray, if you have the video on your other screen.
Thank you. New share. There we go.
In these studies, they were able to make a COVID-19 test from
So I've been spending the last 3 years speaking with families and people in rural and large population areas in Illinois. And when I talk to people who have questions about the vaccines, um, I will do my best to answer those questions and do the standard thing. But another technique that might be helpful is to ask them, where did you hear that? Or how did you find out about that? I'm really interested. Remind them that they are smart, they are capable, or what resources they have, and that you also empathize. We're going through this together. This is a difficult situation for everybody. And just letting them know that there are reliable and standard information out there to ask multiple doctors for their questions if they are wondering, and encourage them to do what's best for their health, as well as to track their symptoms and let you know how they're doing and that you really do care. People will remember how they feel, not necessarily what you tell them or any information. We've all had those situations where we were told we did something or interacted with a patient and we're very confused at why the person perceived us a certain way. However, it doesn't change the fact that a person had an experience that unfortunately might have been bad or even really, really good. It's not always about us. So sometimes reminding ourselves that all we can do is inform people and try to help them and give them time and patience to make their own decisions. And I've been finding that works really well, and people do surprise us over time. So that's what I have.
Thanks, Gray. I think that was a great resource to the video that you shared. And I believe that link was in your slides too, right? So the link that's in chat right now is to Gray's slides. So that video is one of the resources listed in there. So feel free to check that out again. I think that that really does a good job of explaining some of the concerns that people may have about the vaccine and kind of how it was developed. So it's like a nice little succinct version of kind of offering some context around that. So thank you again, Gray.
Yeah. And there's a longer version too. And I just found out today that there are going to be new types of bivirus vaccines potentially coming out soon for multiple types of variants. So it'll be a lot even more complex and more things to talk about with people. So look forward to hearing that.
So at this time, we will still have Gray on the line. So I want to make sure that we take some time to open it up for any questions that participants have for Gray while he's still with us here. And we'll also kind of take this time to transition into the more discussion portion of today's call. So really, again, this is time for you as nursing home leadership to kind of come together, ask your questions, bounce ideas off of each other. So definitely feel free to keep any questions for Gray coming in the chat. But one question I had for all of our participants on the call today. So Kelsey had mentioned that VAERS was one of those topics that we had a previous participant on one of these calls have a question about, request that was something that we address. And so that's why we brought this presentation today. And thank you, Gray, again for presenting. So just to take a pulse, since we have heard that people have questions about this, does anybody on the call have experience submitting VAERS reports? Feel free to just drop it in the chat, a quick yes or no. We just kind of want to get a pulse. Is this something that you're seeing regularly now that COVID vaccines are being given on site, that mobile clinics might be coming? All right, looks like we do have a yes in the chat. All right, some yeses, some nos. So for those of you who did answer yes, what has that experience been like for you? Or what has your leadership team been hearing about VAERS, either from staff or residents? All right, we have one comment from Stacy. Looks like, yes, I had one resident with a reaction that I did report to VAERS. Another comment from Tony, appreciate everything, Gray. Will we have access to the CDC signs, et cetera, that are in your presentation? And Gray, I think those materials were linked in your slides, correct? So everybody after the call today will have those. Okay. All right. So again, for those of you who have had experience submitting to VAERS before, are you hearing anything about it from either your staff or residents or people finding information there? Are they bringing you concerns from that data source in particular? All right, one more comment from Jamie. I had issues with follow-up with VAERS. Fax did not work. I had to send requested docs through mail. Okay, and Gray, I know you covered a little bit of how to submit those forms. Is there like a way that those are usually submitted then?
Yeah, online. I included a link to that online form there too in the presentation.
Okay. Oh, okay. Jamie's saying file size was too big for online submission.
Okay. Well, that's good to know. I wonder if they would accept a zip drive. Thank you, Jared.
It also makes me wonder too, depending on Jamie, when you tried to submit this, if they changed the file size limit, if this is an issue that was, more common than just Jamie, and more folks were encountering this, if they sort of revised that system.
I'm also surprised because when I was going through, first of all, if you want to pull the data, it's actually pretty difficult. You have to figure out exactly which types of information you can get where it's not too much at once, otherwise it'll time out and error. And then when I was finally able to find some of those anecdotal evidence ones, they're incredibly long and incredibly detailed narratives. So I wonder if I wonder if there has been change. So that's a good point.
Looks like the timeline for that happening was in November. Thanks, Jamie. All right, then we do have another comment from Stacy. I haven't had anyone, staff or residents, ask about VAERS. Okay. And then another comment from Vicky. I have a question regarding educating staff who received the primary COVID series and are reluctant to receive the booster. We have a number of staff who are declining booster doses. Any suggestions for education?
So is that question directly for me or does anyone else want to jump into?
Great, if you want to go ahead and start, and then anyone else with perspective, absolutely feel free to jump in.
Okay, great. So I would start asking, what's the general feeling? Where is that idea coming from? Because some people I've seen I had side effects with the vaccines. I had more side effects with the boosters, but regardless of any one individual's situation, every single person and your body is unique and different. So just because one person had one reaction doesn't mean you will, and vice versa. You're never going to have all the information regarding their individual health. You have hopefully access to yours. And even if you do see the information, you're not going to be able to interpret it like a physician would or your individual doctor. So even a doctor, you have to go to your physician and review that. Remind them of that. Remind them that a side effect means that the vaccine is working and their immune system is working. And that's a potentially good thing. And if they have any type of reaction, it'll be nothing comparison to the actual COVID or any virus or any illness that they get. And it only is supposed to last 48 hours. On the rare, extremely rare case that anything does happen, they should have their provider's information for follow-up ready and ask if they follow up and do take care of themselves, show concern, let them know it's not, you're not against them or because it's really easy to dismiss people and they can feel dismissed very easily when you have a lot to do. And we're not mental health providers, right? But we can at least show some sense of compassion of there are some historically based reasons for these thoughts and justifications for people not understanding and help them through that. at least not to feel so alone in that decision.
Thanks, Gray. I think that's a great point about taking time with people, really sitting down to have a conversation and understanding those reasons for why they might be hesitant. And I think that goes really well with the resource that Elena had just dropped into the chat too. So thanks for that, Elena. That link that Elena had added in chat is to a motivational interviewing strategies for vaccination readiness resource that Superior Health Quality Alliance created. And so motivational interviewing, the purpose of that is really to identify people's motivation for getting the vaccine or not getting the vaccine and resolving that ambivalence rather than persuading them to get the vaccine. So that's a really short resource right there at the link, but really helpful, kind of gives some conversational tips for motivational interviewing. And then a couple more comments coming in. From Stacy, I have a lot of staff complain about fairly severe side effects after the second dose or the first booster. I have suggested to those people that they try a booster of a different manufacturer. Okay.
That's a strategy that I hope it's effective. And if you find it is effective, please let me know. But I don't know if we can say that there would be a difference, because that kind of suggests if you're making, that there would be a difference per manufacturer. And we don't have evidence for that. So it's okay to say, I don't know. And that's scary for people, but there's a lot of disparity between staff and infrastructure, especially with nursing. I think we all know people are getting burnt out, and there's mistrust with, again, authority and larger hospital infrastructure. So just validating that, sometimes people want to hear that we don't know, and that will actually help build a relationship long term too.
And I think, Gray, too, to your earlier point about some of that recency, right? Like, you remember how sick you were when you got that first or the second dose, to the thought of having to go through that again, right? For some that were more severe, I think overcoming that could be much more substantial. For me personally, I really didn't have much of a reaction to my vaccines. So when it was time for the booster, I'm like, sure, what's one more? But, obviously everybody's not in that same boat. So, the thought of going back to get another vaccine to be that sick again, you kind of weigh that with, okay, well, COVID may be more mild, we have treatments,
And it's not always hospitalization and death. It can also be maiming, long-term disability, permanent disability, even a decreased capacity over time. And the more times you get COVID, the worse it can potentially get, and the easier it is to get. So, and I mean, the thing is, it's hard. I don't like to scare people, but sometimes telling them the facts can help them with that.
We did have a follow-up comment from Stacy too, that it has been helpful for some people. So I think that's really helpful to know.
It would be interesting if we could study that too.
And then sounds like especially those that get a more severe reaction with each dose, switching manufacturer seems to reduce the likelihood.
Do you have a source for that, Stacy? Because I would like to see that. Maybe I can look it up myself too. I'm an epidemiologist, so like a lot of us here, luckily, health professionals.
Correct me if I'm wrong, Stacy. I don't know if this is just the staff that you've been working with. If it's easier to come off mute and you'd like to share about that, feel free. Otherwise, definitely drop that in the chat. All right, and just keeping track of a couple other comments here too. Elena had dropped another good resource in the chat. This is another one specific to boosters. So that link that's there links to another Superior Health Quality Alliance resource addressing resistance to COVID-19 booster vaccines. And it has some frequently asked questions and answers. So some of those common questions that are coming up about boosters are in there, again, with some information that you can have at the ready just to supply to people. So there's another resource in the chat there, just in case that's helpful.
I also want to acknowledge too, it might be difficult to bring things up, but instances like the Tuskegee Airmen, issues of race, issues of gender, issues of class, these are important to talk about and acknowledge. It may be difficult, and it may be something you don't feel comfortable doing, but practice, and you might worry about making mistakes. We all make mistakes. Practice can help with that, or even just acknowledging that it makes sense that if you see someone like you has been targeted by, or used in that way by a larger institution, it makes sense to be cautious. It makes sense to be wary, but it doesn't make sense to wait too long to protect yourself either. So it is important, and that's where I don't know how to bridge that gap when people are afraid on an institutional level that way. But I do encourage them that the Belmont report exists, ethical standards have been put in place, things do change, albeit incrementally, and that they do have support. And that's why I put that victims instance reporting system in place, and the resources to help them understand, and from their communities, whoever community's perspective, because we all belong to some group, or we all have some type of vulnerability that we deal with every day. It might not be the specific one, but we can relate and empathize with each other. And sometimes it's important to acknowledge that maybe you can't, and maybe that respect needs to be put in place, and maybe they need to talk to somebody who can relate to them in that way.
Thanks, Gray. Some more context looks like came in from Stacy. Just experience. I started recommending the different manufacturer because the health department said that they saw a mix being more effective. I noticed reduced reactions in those that switched manufacturer. It doesn't work for all, but definitely for some. So great context.
Those are great points. Yeah, thank you. It's also hard when the information changes. So keeping those dates in mind, and personally, it's hard for me always to tell a smooth narrative because my brain tends to jump from point to point. Maybe you've noticed that in my slides, but that's why I like things like that CDC video, because it really gives a smooth, calming effect with that type of narrative to help people understand better.
So Gray, I know you mentioned too, so in learning a little bit more about VAERS, I know you had mentioned that there's no way of knowing if vaccines cause adverse events using VAERS alone. So what other data sources kind of need to be used to determine this? Would that be the CISA project that you talked about then?
Yeah, that's the one that providers are supposed to report when they know something has gone wrong. That's the official version. And that's a more reliable one.
Thanks for sharing that resource.
Yeah, no problem. It also takes multiple sources. We can't just rely on one expert or one place. That's why I showed the map. All those, that's just in this country. All those health systems and all those expert groups are working together. This is the first time that we've had an international group of scientists that are able to work together in real time. And I'm honored that I got to be a part of that, albeit for the initial testing phase of COVID-19 in Detroit, but that's never been possible before. We can also thank people with HIV for providing, and AIDS for providing information on how to develop viral vaccines, especially for this too. So lots of work goes into this that I think people don't realize. It would be impossible to coordinate some type of conspiracy effort. And so really explaining how many people care and how many opinions really do, and types of expertise that go into this can really help as well.
That's helpful. Those resources are helpful. I think it's also helpful too to hear from everybody on the call what strategies have really helped you in having these conversations with people who are hesitant about getting the booster. I know we're running close to time, but just one final question too. I know Gray had highlighted some data in his slides, the MMWR graphs, those COVID vaccinated versus unvaccinated cases and deaths. So I know data like this can sometimes be overwhelming. It's a lot to look at, but I'm wondering for the participants on the call, have you been using data like that in those conversations with people who are hesitant about boosters? Has the data been helpful? Have you found a way to kind of present that in a way that really makes sense and resonates with people? Any perspective on that at all, using data in those conversations?
A great question. I forget
Gray.
that just a few years ago, I had to learn all this stuff too. It was, yeah, it was like, what is going on? And I still feel that way sometimes.
I was going to say, Gray, too, if you have like a way that you have seen resonate really well, like presenting that data, feel free to chime in too.
Well, simply walking people through it, trying to keep it simple. I had a supervisor once who I would present a table that I thought was very clear because I made it. And a lot of trust goes into believing people when they present things, which is why we always want to make sure it's from a verified source. We provide the resource. So my resources and references are in the slides at the end when you look at those. And she had no idea, even though the labels were clearly written, and this happens to all of us where we just kind of look at something and we're like, I have no idea what's going on. And even those maps might have felt overwhelming. But just walking someone through and say, okay, well, what are we really seeing? And explaining the standards and norms that in general, we start with our biggest group first, our most general group, and then we break it down step by step. And what does this particular row mean? What does that row mean? Do they add up? Why or why not? Those kinds of things can be really helpful in showing them that there is a data dictionary online. You can look up every single variable, every single column, every single row, and what it might or might not mean. And all of those limitations are outlined in a lot of detail on the CDC website. But always consult a scientist, because even if you look at something, you're going to need help interpreting it no matter who you are. So.
Absolutely. And I do think that's just a good general reminder too. You know, you likely have some staff that are very data literate and can read that and look at it and understand it, and some that may take that out of context and draw their own conclusions that may or may not be appropriate. So I think, you know, this presentation was really helpful, Gray, just to sort of level set what the data is, where it's coming from, what it means, how to interpret it, so that we can equip our nursing home leaders to go out and have these conversations with the folks that might be raising this. So if that is something you're hearing, hopefully the presentation today gave you some better information on VAERS and kind of what's in there, and, you know, that you're more comfortable having those conversations. I know we're almost at the top of the hour, so I just want to have a few quick housekeeping reminders before we close our session today. I see Jerry put the link for an evaluation form in the chat. You could just take a couple of minutes to provide your feedback. We would really appreciate it. And next week, we will be joined by Dr. Buffy for her third session in the 5-part series of Top 5 Infection Prevention Opportunities. So that is ongoing, and we're really excited to have her back next week. And with that, I will go ahead and close us out. Gray, thank you so much again for your presentation. Julie, thanks for moderating the Q&A. Have a wonderful week, and we will see you back next week. Take care.